Teşekkür ederim. Hocama teşekkür ederim.
Thank you very much. I would like to thank Mustafa Bilici, and I also would like to thank the organizing committee of the Congress for extending us the invitation to speak in front of you. Today I will be talking about sleep problems during pregnancy and breastfeeding period, and I would like to talk about psychopharmacological approach towards these problems. Yavuz Selvi said that he also talked about, basic physiological causes of sleep disorders. However, I will be talking about a clinic orientation regarding the subject, and I organized my presentation, which will be tackling the clinical aspect of the matter. Of course, just like the normal population, in pregnant women, there may be sleep disorders, and these are very frequent. And the type of sleep disorders is very much dependent on the trimester. And in the first trimester, sleepiness during the day, nausea, vomiting, frequent urination, backaches, and other physical disturbances, increased appetite and increased anxiety can be the reasons for sleep disorders. In the second trimester, irregular uterus contractions, we call them hysterectomies, and fetal movements, and some problems with the stomach and snoring can be very important for disturbance of the sleep. And in the third trimester, on the other hand, a majority of the patients may complain about many disorders with regard to sleep, especially restless sleep, and a great number of waking up during the night. And the reason is that the continuation of the symptoms starting in the second trimester. In the third trimester, frequent urination, leg cramps, breathlessness, and also some problems with the stomach, and some forced positions in the bed may cause sleep disturbances. Just like that, backaches, carpal tunnel symptoms, and prolactin occurrence in the breasts, and ductus development, and also growth in the breast, and also there can be discomfort in breasts as well, and itching is also another problem for sleep disturbances in the third trimester. Of course, in the third trimester, there are some internal and external factors which play a role. In terms of internal factors, we can say the delivery, the labor, fetus and pregnancy complications, and also some daydreaming and also some nightmares can affect sleep disturbances. There are some external factors as well. For example, the voices of the other children, if there are any, their needs, and environmental noise and environmental sounds may have negative impact on the sleep orders of the pregnant women in the third trimester. Of course, during the pregnancy, primary sleep disorders may occur. However, already existing sleep disorders may deteriorate over time. So their situation may get more severe. So what kind of sleep disorders are seen during pregnancy? For example, respiratory disorders related with sleep, for example, intermittent snoring without any apnea, for example, and obesity hypoventilation syndrome can be the two extremes on the spectrum, and there can be many other problems, and there is no specific pharmacological treatment for respiratory disorders regarding and related with sleep, but there are some special methods like CPAP, and they can be treated for these disorders. There is another big group, and these are the movement disorders related with sleep. The first one is the leg cramps. As you know, the frequency is increasing towards the labor. We do not know the mechanism very well, but intra-abdominal pressure is increasing, therefore venous reversal is slowing down, And also there are some changes in calcium, magnesium, and protein metabolisms, and in the treatment, tablets containing magnesium are used. The obstetricians are trying to prevent uterine cramps, and in order to maintain pregnancy, they are giving them magnesium support. And tablets containing magnesium are very important for preventing the cramps by improving the metabolism problems. Another important group is the secondary restless leg syndrome related with pregnancy. The frequency is between 3 to 30% in pregnant women, and in the general population, if there is no previous syndrome, if it is the first onset during pregnancy, then we say that in the second trimester it is occurring. There are different risk factors like advanced age, being overweight, being more than 79 kilograms, and also we talked about respiratory disorders which accompany sleep, and periodic extremity movements during sleep, and also smoking and positive family history, and these also pave the way for having restless leg syndrome in the pregnant women during pregnancy. But about etiology, these are the factors that we're all familiar with. For adult patients and for adult male patients, these are important risk factors as well. As you know, iron deficiency and iron deficiency anemia have the same etiology for pregnant women as well. Folic acid insufficiency, hormonal changes, and psychomotor behaviors may also cause a restless leg syndrome as a secondary category for pregnant women. So let's talk about measures, and let's talk about preventive precautions. In the second trimester, iron addition, and iron should be added to their regimen because they don't have to develop restless leg syndrome. And 3 months before becoming pregnant, 0.5 milligram a day folic acid should be started. Those women who are planning to become pregnant, they may come to us for some reason, and 3 months before they get pregnant, they should start folic acid. And for pregnant women, it is 0.5 milligrams a day, so they should be taking this amount. But if they are using an anti-epileptic or antipsychotic, if there are other conditions which may increase the risk, the daily need is multiplied by 10, and they should be taking 5 milligram tablets. And they are available on the market, and this also reduces the risk of the onset of the disease. So what do we do in treatment? If deficiency is identified with regard to vitamin B, vitamin C, what should we do? We should be, of course, replacing them. If there is a substance use or a drug use which may cause abnormality in pregnancy, we should discontinue them, like caffeine, alcohol, and nicotine use increase the risk. Antidopaminergics, SSRIs, SNRIs, NSA, and antihistaminics, and some psychotropic drug use is also increasing the risk. And if we cannot solve the problem with these, non-pharmacological methods are applied as well, because in pregnant women and breastfeeding women, as mentioned by the previous speaker, we have to avoid drugs, and we should be using drugs as a last choice and as a last remedy. If we cannot solve all these problems in the restless leg syndrome with all these alternative methods, we start pharmacological treatment. In the third trimester, we use with the most efficient dosage and with the drug which is more suitable for the pregnancy category. So in this type of patients, if they are pregnant, if they are breastfeeding, you have to talk to them, and you have to inform them, and you have to present them all the choices, and you should be sharing the risks and the responsibilities with them, and you have have to discuss them. You have to discuss with them, and you have to have the best choice available. You have to get their informed consent, and you have to keep the polyclinic records very well, and you have to take note of everything so that we can get away from legal, administrative, and other problems. So instead of starting a drug, you should be discussing all about these matters with the pregnant and breastfeeding women, and you should start the drugs afterwards. So if you get informed consent, you will be preventing in advance any possible problems that may occur in the future. Another problem is insomnia related with pregnancy. Insomnia is one of the most frequent psychiatric disorders in the general population as well. It is mostly seen in pregnant women as well, because majority of women are living one or more symptoms of insomnia, and very few people with insomnia can say that they can sleep well. Therefore, pregnancy-related insomnia is seen very frequently. So what types of insomnia? For example, low sleep quality. They may have difficulty in getting into sleep, they may have difficulty in maintaining the sleep, and they may wake up very early without any rest. They may feel tired during the day. There can be irritability, and there can be lack of concentration. Of course, because of its nature, insomnia is considered to be secondary. And the trimester of pregnancy, when it occurs, also may affect the type of insomnia. As you know, there is not a single type of insomnia, but the most deteriorated and the most distorted sleep is in the third trimester. And sometimes we may see that it can be secondary to a primary sleep disorder which deteriorates over time. For example, there is no insomnia for the patient, but a restless leg syndrome is developing in the 7th month of pregnancy, and the woman was want to move her legs all the time and cannot get into sleep. So this is secondary in that case, and until the primary problem is eliminated, it may continue and it may be maintained, and we have to be careful about that as well. Throughout pregnancy, physiological hyperactivity symptoms can occur. For example, increased metabolism rate and increased heart rate, and these symptoms are seen as common symptoms with patients of insomnia. So in addition to this, a majority of women are suffering from increased anxiety and increased emotional disorder. Physiological hyperactivity symptoms are already there, and when it is coupled with increased anxiety and comfortlessness, it may deteriorate the situation, or it may be a triggering factor for insomnia. And with the introduction to the third trimester, majority of women are getting aware of the life-altering change, and they get concerns. Of course, until then they are concerned, but the labor is getting closer, and they have a big belly, and they are feeling heavier. Therefore, their concerns are increasing, and these concerns may affect their sleep order. So this cortical alertness is combined with physiological hyperactivity symptoms, and in that case, they cannot get into sleep during the night, and during the day, they feel always sleepy. So, of course, insomnia should be treated in pregnant women because it affects life quality and daily functionality very much. Of course, the priority is given to non-pharmacological treatment, but if they cannot give result, the cost-benefit ratio should be, and risk-benefit ratio should be calculated, and you should get informed consent, and with the lowest dosage possible, and with the most suitable agent, you should be treating insomnia for pregnant women. Another problem is nocturnal gastroesophageal reflux. And I think, as you know, progesterone is increasing, and it causes relaxation in smooth muscles, and that relaxation is causing the regurgitation of the content of the stomach, and it comes to the mouth, and therefore they are caused during the night, and it causes disturbance in the sleep order, like regurgitation, nausea, and vomiting, and restlessness in the chest, cough, and a feeling of suffocation, and the other problems may occur, so they cause deterioration on the sleep quality. And as I said before, some non-pharmacological methods may not be enough, like lying on the left side and changing the lifestyle and diet habits or eating habits. So in that case, antacids and similar drugs can be started. Another group is parasomnies. And together with old age, we see less dreams and less colorful dreams. But pregnancy is just the opposite. Together with gestation, frequency of dreaming is increasing. And we talked about concerns, as you will remember. And with these concerns, they may dream very frequently, and they may have nightmares. So the pregnant woman or the other persons around her may be affected by this, and bedroom should be arranged accordingly. Narcolepsy is not very jeopardizing, so cataplexy and falling down may be unpreventable. Therefore, the fetus and the mother can be harmed. So in that case, you have to consult with the obstetrician following the patient, and C-section indication can be considered. Of course, long-term effects on fetus have not been investigated by controlled studies at the moment. Therefore, non-pharmacological treatment approaches are in the foreground. But if there is open-ended needs, the drugs can be administered within the precautions that I mentioned before. So why do we treat sleep disorders in general terms? Because these sleep problems may have a lot of negative repercussions, together with the maternal complications, and together with the sleep disorders which affect respiratory order, gestational hypertension, preeclampsia, gestational diabetes, pulmonary hypertension, other cardiovascular diseases are related with that, and fatal complications may also be under the question, because uteroplacental blood flow and growth hormones and some other neurohormones are having their peaks in terms of secretion during the sleep. Therefore, when there is a sleep disorder, the fetus development may be affected, and for the growth of the fetus and for the development of the fetus, so we have to prevent them. Even hypoxemia can affect the fetus, and because it may cause low birth weight and also developmental retardation and low Apgar scores, and even a more significant mortality risk may be present for the baby. There are certain pregnancy complications. For example, the pregnant women who are sleeping less than 6 hours have more C-section frequency compared to women who are sleeping more than 7 hours or who are sleeping with more quality. So the sleep cannot be replaced. Therefore, during labor, the pain threshold is increasing and pain sensitivity is increasing, and those women who are feeling a lot of pain are open to these type of complications. There are psychosocial complications. The mood is affected, emotional sensitivity is increasing, interpersonal functionality is deteriorating, physical and emotional stress is there. There is depression, there is lack of concentration, attention, memory loss, and also there are some daily activity and functionality problems, and some pregnant women as a result of this may fall down. And there's gestational diabetes, and chronic partial sleep loss is also affecting them. And finally, I would like to talk about postpartum lactation period. If there is no problem, these sleep disorders which occur during pregnancy are improved after birth, especially in the first 6 months after birth is covered by this. However, then there should be breastfeeding, and these may cause sleep disorders. Non-pharmacological treatment is given priority. However, if we cannot obtain positive results from these methods, some suitable drugs can be used, but we have to bear in mind that sleep disorders may also increase the risk of postpartum depression. Therefore, during the postpartum period, the patients should not have sleep problems, and we have to solve their problems in that respect. This is a table, and I will be showing it very briefly, and I will be skipping it later on. As you can see here, there are classifications and there are categories of pregnancy and categories of drugs. Zolpidem is not present in our country, but diphenhydramine category is D. Tablets, capsule or dredge is not present. There is the syrup, and diphenhydramine syrups can be preferred in order to prevent insomnia and sleep disorders. And dopaminergic agents are also present. Dopaminergic agents, as you know, when the legs are restless and when the pregnant woman is in need of moving the legs, these dopaminergic agents are used. For example, pramipexole can be used, pexaroropinol and carbidopa, all of them can be used, but their category is C. And in the last 3 months, maybe, when it is a real must, with the lowest dosage possible, they should be administered, because pramipexole, for example, can be used between 0.125 to 0.75 dosages, and they should be used for the shortest extent possible. Other than that, narcolepsy is an important situation. For narcolepsy, the pregnancy category is also C, for example, modafinil and methylphenidate. Both of them are present in Turkish market. They can be used, but as I said before, there are no longitudinal studies, and the risk-benefit ratio should be considered before administering these drugs. And in terms of panosomnias, the relevant drugs should be used accordingly. This is a new source which was published in 2011. However, according to some sources, pregnancy category is C, but for some sources it is D. But we have to accept them as pregnancy category D. During the lactation period, it's a good agent. However, during pregnancy, it should be accepted as category D, and paroxetine should not be started as an SSRI for pregnant women. Of course, there is the lactation period. In the lactation period, the situation is even worse than pregnancy. As you can see here, L2 is very rare. Usually, the lactation risk category is 3 for majority of the drugs. And for using majority of the drugs, we should be stopping breastfeeding, and we should be using bottled milk. But in that case, we should be using the lowest dosage possible and the most suitable drug during the lactation period and the pregnancy period. I would like to recommend you some sources. For example, there are books of sleep medicine. There is a Turkish researcher working in Pennsylvania, and he has published a lot of publications. Catherine Lee is a very important author, and she's working in California, and she has a lot of articles and publications. And very few guidelines are available. However, one of them is very good, and you can read it. And we also co-authored with Nazan Hoca about psychotropic medications used during pregnancy and lactation, and it is newly published. And if you are interested in this field, you can read them. Thank you very much for your patience.